Well, good day, everybody. Glad to see, well, at least somebody of you, not many, at our class. And once again, I'd like to ask all of you to switch on your cameras so that you'll be able to control that actually you're attending the class. It's you, not somebody else instead. As usual, as in the previous class, I will post the link to the Google Class form. Please copy that into your browser and try to fill down your name, today's date, that actually you attended the class. Good. Today's class, yes, and the second point is once again, I would like to ask all of you to use the web page of our university. I just will post a link to web page of university in my Google Class, so that all our activity should be mediated through the web page of university. We have to migrate to that platform. Maybe not quite convenient. It's not as useful from the point of view of the feedback. It's difficult to assess, for instance, MCQs. But we have to do that just for official reasons, because our officers would like to control, check everything, and therefore everything should be registered. So if you'll click a link to our Zoom conference in the web page, that will be recorded as your activity at today's class. Good. So therefore, for this class, I posted the direct link to the Zoom in the Google Class, but I would like that will be the last time, and I'll just post link to web page of university, and from the web page you may find the link to the Zoom. Good. Now we need to shift to today's topic, actually topics, because for today we have to discuss cardiac murmurs, and our topic that was waiting for discussion from the I think previous week, that was the examination of the veins of the patient, jugular vein, venous pulse, and that will be also something that we have to discuss today. Good. Talking about cardiac murmurs. First of all, we need to assess presence of the murmur from the point of view some simple physiological things, from the point of view of the basic cardiac physiology. So first of all, we need to find out actually where it is localized, the area of maximal intensity. That's important, and unfortunately, it's not always easy. The problem is that murmur may be heard sometimes over the whole precordial area, and therefore, by location of the murmur, we need to find out actually the maximal intensity. So, if, for instance, it will be heard over all 5 standard points for auscultation, find out where is the maximal intensity of the murmur. Second will be the timing. We need to correlate presence of the murmur to presence of the systole and diastole. And can somebody tell me how can we find out where the patient's having just now when we hear murmur, systole or diastole? What will be the basic marker that, for instance, a murmur that you'll hear after a sound is systolic or diastolic? Any ideas? Maybe Gabriel, Kadil, any ideas? Somebody else? No?
Professor,
Yes.
maybe the sound.
Yes, Mike.
Yes, I mean maybe the sound that like maybe that I'm not sure, but maybe that the second sound, like it starts or after the end, it ends, and it's like the first sound, it didn't end, the second sound starts. Maybe
Uh,
like this.
it may be different, but point is that you have to find out which sound is the first, which is second. So you may hear two sounds, and whether it's well, actually it's a little bit group of sounds. How to find out whether that is S1 and that is S2, or whether it's vice versa. It was previous S2, that is S1, and that is another S2. So how to decide whether the sound that you are hearing now and that is followed by the murmur is first or whether it's second.
S1 occurs in systolic murmur occurs in between S1 and S2 sound.
Yes, but how to find whether it's S1 or whether the sound is S2?
S1 will be louder in the heart apex, and S2 will be louder in heart base. So maybe in that way we can do it.
Yeah, exactly right, but that is true
And
only for
more,
healthy patient. In the case of affection of myocardial muscle, there may be a different situation when there will be decrease S1, for instance, at the apex, and will be lower intensity in comparison to S2. Sorry. Well,
Do we check where the valves project in the chest?
no, no, that's not helpful. First of all, the projection of cardiac valves is basically same single area, and that's why it's not as helpful. Second, well, there may be a situation when patient will have changes or murmurs related to different cardiac valves. So point is that S1, that is systolic murmur, will be diagnosed by the basic marker of the systole, that is the pulse wave on the carotid artery. If the sound that you hear, for instance, this one, will develop just before, will be just well followed by the pulse wave on the carotid artery, that is the first cardiac sound. If during the auscultation there will be no pulse wave just well after that, that is the second cardiac sound. So please try to correlate what do you hear to pulsation of the carotid artery. Unfortunately, radial artery is small one. There will be
excuse me,
significant
sir.
delay. Yes, yes, Paramita. Okay, if you still,
Hello,
yes,
sir.
yes, good day,
Yes,
Paramita.
sir. I'm sorry. I'm saying that if we check with our stethoscope, then we will not get the ECG machine in front of us. Then how can we relate it?
Not
Or any other
ECG.
machine? We
Well,
have only
definitely,
stethoscope.
definitely, ECG is fine, and that's quite helpful. So, if you would have ventricular complex, after that there should be S1. Yes, that's true. But if there is no ECG machine, then you have your own fingers, and you have a carotid artery. So that is a pulse wave on carotid artery. And if just before you'll hear a sound, that is obviously S1. If there'll be no pulse wave on carotid after the sound that you hear that you try to evaluate, that is
So,
second
sir,
cardiac sound.
actually, then it means carotid pulse, that is synchronous for the first sound and asynchronous for the second sound, right?
Uh, Carotid artery pulse will be synchronous to S1.
Yes, and asynchronized to S2.
Yes, exactly.
Okay, thank you, sir.
Good. Fine. So, well, first was definitely location. So we need to find out where the sound is located. Second was the timing. We need to decide whether it's systolic, diastolic, or it may be biphasic. So continuous, it's quite well uh, um, ambiguous term. It may be continuous within the systole. No, It may be biphasic, it may be a systole plus diastole. For instance, pericardial murmur may be biphasic, or murmur in, for instance, ventricular septal defect. Third point will be the shape of the murmur. It may be increasing. We call that, I think it will be, well, don't know whether it's Latin or maybe Italian, crescendo. It may be decreasing, so it will start with maximal intensity and then go down. That will be decrescendo. It may be diamond shaped, so a combination of both. It will be first increase, then decrease, like a diamond, and that will be a crescendo, decrescendo murmur. Or it may be a plateau murmur when there will be stable intensity of the murmur within the phase of the heart, whether it's systole or diastole. Now, sometimes that sound may be called holosystolic, but point is that there should be same intensity, plateau. Good. Just a little bit later, we'll discuss what will be the factors that will determine the shape of the murmur. It's quite important from the point of view of understanding of cardiac pathophysiology. Radiation or transmission of the murmur, factor that will reflect the direction of the blood flow, the change in the murmur intensity, very important factor. It will show you the direction of the turbulent blood flow that will develop in valvular heart disease. So, for instance, I think we'll discuss it once again, but let me show you right now. For instance, we're talking about a patient with, that will be the aorta, with mitral incompetence, and there will be turbulent jet through incompetent mitral valve from the left ventricle into left atrium, from, well, down upwards. And radiation will be from the apical point, from the apical impulse, slightly laterally and up to the left axillary area by the outer margin of pectoral major muscle, just alone in the same direction of turbulent jet of blood. If you talk about, for instance, patient with the stenosis of aortic valve, block of the normal ejection of the blood from ventricle to aorta, and obviously to all other great arteries, subclavian arteries, carotid artery, may be thoracic aorta. The turbulent jet of blood will be everywhere in all great arteries of greater circle. And therefore, there will be maximal intensity of the murmur. Location of the murmur will be in aortic area, second right interspace, and radiation will be to subclavian arteries, to carotids, and maybe to the interscapular space at the back. That's important, and unfortunately, sometimes it may be tricky, sometimes it may be confusing, because in some cases, radiation will be explained not by the direction of the turbulent jet of blood, but by mechanical properties of the chest wall. There may be radiation by ribs, by the sternum, by pectoral muscle, and that may be sometimes confusing, so we'll try to discuss later how we should try to differentiate that. Pitch, it's important, whether it may be a high frequency murmur, medium or low frequency, and once again, maybe somebody, parameter, hello, nice to see you. No, please switch on your camera back. Don't be so shy. Can you tell me, yes, parameter, that would be the question to you. How can you differentiate, again, having no technical devices, no PCG, for instance, device, or ECG device, cardiac ultrasound that also records the cardiac sounds? How can you differentiate low pitch murmur from high pitch murmur? Again, at physical exam, when we have just your phonendoscope or stethoscope, how we can do that? Please pay attention that I told you about stethoscope, that is a tube, or phonendoscope with a membrane. So that may be the clue to our problem. Presence
Yes, sir.
of membrane.
Yeah. Maybe, sir, it's actually, I've studied from heart murmur that the narrow tube, if the velocity from there is more, then the noise will be more, and thus we can hear it. And maybe from the membrane we can do so.
The point is that membrane will amplify high frequency
Uh,
murmurs to high extent. Yes.
yes, the vibration. The
So
vibration through the diaphragm
membrane,
will go.
that is a tube, that's a stethoscope that actually did not change significantly from the time it was wooden. It will conduct more or less evenly all murmurs. But membrane that was added will act as an amplifier, but amplifier is quite selective. It will amplify in high degree, high pitch sound, and there'll be almost no amplification for low pitch sound. So therefore, if you have your double-sided phonoendoscope, you should dismount the membrane from one side and try to auscultate patient first without membrane. There'll be no membrane. Then switch to presence of membrane, so to phonoendoscope. And if there will be significant amplification, that is a high pitch murmur. If there will be no amplification, that is a low pitch murmur.
Professor, excuse
Yes.
me, I didn't get this. How can I hear this with my phonoendoscope?
So typically a phonoendoscope, let me draw maybe in a better way. That is a rubber tube that will be connected to common cavity. And typically you have on one side, just a bell. So there'll be no membrane. And on the other side, there will be a bell, but with a membrane. So that is the membrane that will vibrate. And you may switch from one side because there'll be the orifice only on the one end of the tube that is inserted into double-sided device. So we switch from the open tube, so there will be open channel from the bell up to ears. To you may switch to membrane that will vibrate, amplifying to high degree high pitch sound. So just twisting the tip of your phonoendoscope from stator without membrane to phonendo with membrane, you may filter high pitch sounds from all other sounds. So if they will be amplified, that is the high pitch murmur, like that. Quality that may be required some kind of musical education, whether it's soft blowing, whether it may be rough and harsh murmur. And that's important because it's typical for some certain valvular heart diseases. Typically, a lot of mitral murmurs will produce harsh. Mostly aortic will be soft and blowing, though aortic stenosis quite oftenly will produce harsh murmur of low pitch. So it depends upon certain specific disease, and you have to know that. So which quality of the murmur will be associated to which valvular heart disease. Intensity. It's a little bit outdated, but still in all textbooks we have so-called Levin scale that was first published in 1933, and there is 6-grade scale reproducing different degrees of intensity of the murmur. So first grade means that at careful concentration you can barely hear the murmur. Readily detected but faint means that you have second grade. Third grade, the sound will be easily detectable. No concentration is needed. It's obvious. You just will position your phonoendoscope at the patient's chest and hear the murmur. Louder and even louder than third degree and palpable means that there will be fourth grade murmur. By the way, please pay attention that typically low pitch murmurs will be more easily palpable. High pitch murmur will be palpable only if it's very loud, very intensive. It's also possible, but low pitch murmurs will be more easily perceived by your hand. It will be something like tactile parameters, vocal parameters. So you position your palms on the patient's auscultation area, and in the same location where you just we're holding your phonoendoscope, you may feel a vibration like as if the patient will be saying something. Audible with just slightly touching of the rim of a stethoscope means 5th grade, and actually I never saw a person who will use auscultation without stethoscope. But if you happen to auscultate the murmur, in that case, means that you are getting 6th grade of the murmur. Good. And definitely we need to correlate, we need to describe precisely the murmur from the point of view of what will happen if patient will breathe in. And Safar, Ali Safar, can you please tell us which murmurs, which auscultatory data will change in the case of breathing in? So if you ask patient to breathe in deeply, in which case murmurs in the heart or changes in cardiac sounds will become amplified. Ali Safar, I cannot see you and I cannot hear you. Are you actually with us? Troubles? Yes, Ali Safar?
Yes. I think maybe first sound. Sorry, I charged my phone. That's why I closed the
I see.
camera.
So again, you ask patient to make a deep breath in, and for instance, let's say murmurs will become amplified. It means that those murmurs were coming from what? From which areas, from which cavities of the heart?
Maybe
Yes, Gabriel?
Friction?
Sorry, Gabriel?
From pleuropericardial friction?
From pleura?
No, pleuropericardial friction.
Pleuropericardial?
Yeah.
Maybe, but for differentiation of that, you have to assist as patient not to breathe. That will be important to differentiate pleural from pericardial rub. Ali Safa, any other ideas?
I think maybe from the apex of the heart, but I'm not sure.
No. If the
No.
inspiration will increase, that will be related to right cavities of the heart, and that will be most obvious at the tricuspid area, that is base of the xiphoid process, and left second interspace. We need to pay attention to position of the patient. We'll discuss it later. And some other special maneuvers like squatting, for instance, for the salvo maneuver, or some others. Good. That is something that is extremely helpful for our purposes. That
Excuse me.
is, yes?
I didn't understand your question in relation with the inhalation.
Okay. I think we'll discuss it once again later, but let's, I will draw a little bit now. So point is that we have two more or less independent pumps, the left ventricle and right ventricle. Left ventricle will receive blood from the lungs. And if patient will breathe in or breathe out, there'll be no significant change in delivery of blood, return of blood from left circle, from lungs to left atrium and then to left ventricle. So breathing in or out will not significantly alter the functioning of the left ventricle. If we'll pay attention to the right ventricle is located in the same location as lungs, and therefore at breathing in, the pressure will go down, and that pressure, well, negative pressure, that will bring the air into patient's lungs, same negative pressure vacuum will bring the blood to the right atrium and right ventricle. The blood will be delivered, will be returned in significantly higher degree during the inspiratory phase due to negative pressure in the chest, and same constant pressure outside. So pressure will outside the chest will be normal in the head, upper, lower extremities, in the abdomen, while pressure in the area of the right ventricle will significantly decrease. So the venous return will be increased. And therefore, if there will be something wrong with the right cavities, any murmur, that will be amplified in the case of breathing in contrast to the left cavities of the heart, that will be significantly unchanged, like this. Good. Well, ECG, that is classical two-dimensional echocardiogram with the Doppler charting. That is again very convenient for our purpose. So point is that how can we correlate what do we see at ECG to what do we hear? First, please pay attention to that diastolic chart. Probe is here. That is also at the top. It radiates down and it receives return of the echo from the lower areas upwards to the location of the probe. So probe is here, and what do we see is the movement of the blood from left atrium to left ventricle. That is smooth, and that is laminar. First point, why it is smooth? Because it is evenly stained in the tints and the grades of the red. So first, because it's more or less uniform in its tint and its color. That's why it is laminar. Second, why the flow is from left atrium to left ventricle? Why it is diastole? Why I said that flow is well, like that? And it's not regurgitation in patient with mitral competence because the color is red. Red means the direction towards the probe. If there will be flow away from the probe, the color will be blue. Therefore, you will pay attention to that systolic chart. What do we see inside the left ventricle is again uniform blue tint. And we see that there may be some just will slightly change from darker color to brighter color, different velocity of RBCs, but it's quite uniform in comparison to what I'll show you later. And the direction is away, but it's not into left atrium. There is no well significant jet of blood just well above. So that will be well our apex. So I will call that above a mitral valve. It means that that flow away from the probe is not into the left atrium. It's into aorta. So we need to just well slightly change the direction of our probe from the four-chamber position, that's classical position when the probe will be at the apex. And in that case, you'll be able to see the well, flow into aorta. But we will be sure that it's not into atrium and it's definitely away from the left ventricle because it's away from the probe. That will be the normal situation. And in that case, you can see that first, well, in that location, there is a jet of blood into aorta from the left ventricle. It's a position of the probe that, well, the outlet of the right ventricle gives the jet, well, towards the probe because that's why it's red. And in aorta is going slightly well away because that's why because it's blue. But point is that we also see the jet of blood into left atrium. And it's far from uniform, it's mosaic. It means that it's not smooth, it's not laminar. There are turbulences over there because of different tints of color. That's how Doppler mode will significantly help you to understand your auscultatory data. Definitely, you'll send all your patients well, after auscultation to ECG. It's important because you need to understand what's happening to ventricular muscle. That's why, because it's helpful to visualize heart valves. But beside that, if you switch to Doppler color mode, it may visualize murmurs that you just well heard by your phonenoscope. That's important. That's very helpful. And don't forget that besides ECG, most of cardiac ultrasound devices can also record ECG. Sorry, can record PCG phonocardiogram. So you may hear your well sounds first, second sound, some murmurs. It's also quite convenient because you'll have visualization of your auscultatory data directly. Good. Okay, let's go further.
So,
Yes, yes.
does it mean that there must be incompetence in the atrioventricular valve?
Well, in this case, yes. So if you have the two jets of blood forward, quite smooth, and backward from left ventricle to left atrium, and it's turbulent, obviously it means that your patients have an incompetence of the mitral valve of the left AV valve. What will be the basic types of systolic murmurs? We'll discuss them in details, but very, very briefly. That is midsystolic murmur with the maximum intensity during the mid of the systole. It's diamond-shaped with a slow increase and decrease of the murmur. That is the pansystolic holosystolic murmur. It's stable. That is crescendo murmur at the late of systole. That is decrescendo, and again decrescendo murmur that starts at the, not from the onset of diastole, somewhat later, typically after some extra sound that should be present here. And that is crescendo presystolic. Late diastolics murmur is well, quite unusual term. Typically, we'll call them presystolics murmurs. Well, that is very important slide that actually shows the significance of the shape of the murmur. There are several examples of murmur in different well, heart diseases. Yes, by the way, well, talking about well, the question concerning the mitral incompetence, that is the mitral incompetence. That's why we are paying attention to the left atrial pressure. That is the lower portion of the curve. And left ventricular pressure, that is the green curve. What do we see in a patient, for instance, this patient with plateau murmur during the systole? We can see a more or less stable degree of the pressure gradient. So the well, light blue area, that is the area of pressure gradient between left atrium and left ventricle. And it's more or less stable during the systole, with actually some slight increase that in some cases also may be visible or audible during auscultation. But if it will be more or less, well, same pressure gradient all over during the systole, you'll get plateau murmur. Another situation will be in a patient with a diamond-shaped murmur. You can see there is increase and decrease. Now, that murmur may be seen in a patient with aortic stenosis. So that is the pressure in aorta, and that is the pressure in the left ventricle, the green one. Left ventricular pressure is almost normal. It's going up, it's reaching its climax at the midst of systole. But please pay attention to the shape of the pressure gradient in relation to aortic pressure. In comparison, in contrast to left atrial pressure, the pressure in aorta also will go up, but with some kind of delay. And therefore, in the middle of the systole, maybe slightly earlier, you'll get highest pressure gradient. It will be smallest at the beginning and at the end of systole. Therefore, you'll get diamond-shaped shape of the pressure gradient and diamond-shaped murmur. That will be murmur in aortic incompetence. Again, we are paying attention to aortic pressure. That is left ventricular pressure. And in this situation, we are dealing with a patient when blood will go back from aorta through incompetent damaged aortic valve back into left ventricle. So that's why we're paying attention to aortic pressure. That will be the diastole in aorta and pressure in the ventricle. Ventricle will relax very, very quickly. The pressure will drop very rapidly, and therefore we'll get maximal pressure at the very beginning of diastole. That will be the highest pressure gradient here. And then, well, later on, there will be more and more blood in the left ventricle. It will be filled by blood, by the way, both from aorta and from the left atrium. And the pressure will slightly go down in aorta, and therefore, along with diastole, there will be decrease in pressure gradient. Decrease in aortic pressure, increase in ventricular pressure will give decrease in the pressure gradient, decrease in turbulent jet of blood, and decrease in the murmur. So murmur will be decrescendo, decreasing. And please let me not discuss that, because that actually is quite complicated. A picture that is a picture of mitral stenosis. And in this case, we have two components. It will be passive component that will produce mid-diastolic murmur. That will be the active component due to atrial contraction, resulting in pre-systolic murmur. It's quite complicated. I think we'll discuss it somewhat later, partially today, and mostly at the class devoted to mitral valvular heart diseases. I think that will be maybe in a week or like that. Once again, talking about location and radiation, that is mitral regurgitation murmur. The climax, the maximum intensity of the murmur will be obviously at the apex. And radiation will be, so that is patient's heart, left ventricle, left atrium. Blood is regurgitating from ventricle into atrium upwards, and that will be the basic direction of regurgitation, upward. Well, by the outer border of the pectoralis major. Yes, unfortunately, you should not remember, should not forget, should remember that direction of irradiation. By that, you'll ask me, well, yes, unfortunately, there will be not always explainable radiation. That will be radiation by the surface of the cardiac muscle, by the muscle of the left ventricle itself, by the ribs that will be located in that area, by the sternum. There will be radiation that will be anatomical, not associated to the pathophysiology of the cardiac disease. Therefore, well, definitely sometimes you will be confused that the murmur, for instance, will be heard over the whole precordial area. Don't be disappointed. It's not the problem. Please pay attention to some logical conductions, radiations of the murmur to the areas where it cannot be radiated by the bones or muscles. For instance, to the left axilla. If the murmur will go to that direction, definitely that cannot be due to pectoral muscle. If you'll hear the murmur over the aortic area, maybe sometimes conducted downwards, backwards, maybe conducted by the sternal bone, or sometimes to the area very close to the apex. Don't be confused by that, because no other murmur but the murmur of aortic stenosis will be conducted to carotids. No other murmur will be conducted to subclavian arteries. No other murmur will be conducted to descending aorta and may be heard in interscapular space. That's why it's important to auscultate some other distant areas where conduction of the murmur will be only due to the turbulent jet of blood, not due to the bones or muscles of the chest. That is, by the way, the location of the very rare murmur in ventricular septal defect. Never in my life I had a patient with that disease, but I'm not a cardiologist. So anyhow, those patients typically are treated in childhood. And don't forget about the vibrations. Vibration in many cases will be palpable in the literally precordial area by the directly by the left and right edges of the sternum. It's typical for mitral regurgitation, and it's very typical for aortic stenosis. It will be palpable in the aortic area and will be palpable in the precordial area. Again, very briefly, because we'll discuss that, we'll talk about heart disease once again in much more details. Briefly, a list of basic valvular disorders. In mitral stenosis, the timing of the murmur will be double. It will be mid-diastolic, and it will be late diastolic, that is pre-systolic. So there will be two types of the murmur. Characteristic typically will be rumbling, very rough murmur, and of low pitch, rough timbre. Location definitely will be apex, no radiation from the apex. And a mild physical activity like squatting, for instance, will amplify that murmur. So there will be amplification after exercise. Murmur will be best heard if you will position your phonendoscope at the apex. Will use your middle finger to press your phonendoscope to the apex area. Your patient is lying on his or her back, and then holding your phonendoscope by your middle finger, you will turn your patient to his or her left side. So that patient will be lying by the apex of the heart on your phonendoscope. So phonendoscope will be underneath your patient. And in that case, again, a murmur will be amplified. It will go up. It will be increased. Mitral competence. Pansystolic murmur during the whole systole, loud but blowing, soft quality. Location apex. Radiation, as we decided, will slightly laterally and upwards, and it will be audible in all postures, but maybe slightly better at the left lateral position. Aortic stenosis, mostly mid-systolic murmur. Well, formally it will occupy the whole systole, but the maximum will be at the middle. Harsh quality, location will be in the second right interspace. Sometimes may go down, and the most important, the radiation will be to the neck, blood vessels, to subclavian arteries, and other great arteries. For auscultation maneuvers, first of all, give the heart ability to attach to come closer to the chest. Ask patient to breathe out. We need to remove the pulmonary tissue in between patient's heart and the chest wall. Therefore, exhalation first. Second, a patient need to be seated and leaning forward again. In that case, heart will come closer to the anterior chest wall. Aortic incompetence, early diastolic murmur decrescendo, it will be typically soft, blowing, very gentle. Location, typically left parasternal. Left parasternal means accessory area, Botkin's area, Botkin herb area. I don't think that we have to discuss Austin Flint murmur because it's different. So it's not same as the murmur that we're discussing. Austin Flint is the extra murmur. We'll talk about it later. So it's just something to which basic murmur will be combined to. It's extra sign, extra murmur. Same position, best heard at exhalation, and patient should be leaning forward. Well, what else we can do? Well, to increase venous return, you may ask patient to try to breathe in with the nose closed. So patient needs to close his nose and try to breathe in. That will be the Mueller maneuver. Again, that will be increase the murmur as well as inspiration, murmurs related to the right side of the heart. And obviously, expiration may slightly increase murmurs related to the left side of the heart, mostly for the anatomical reasons, mostly just because we remove the pulmonary tissue that will isolate left ventricle by that maneuver. What may be the other maneuvers? It may be just some kind of physical activity, squatting to standing maneuver. So you auscultate patient, he or she will squat, and after a patient will stand up. And Valsalva maneuver, trying to exhale in the case of mouth and nose will be shut. They'll both decrease. Valsalva maneuver due to increased pressure in the chest, squatting to standing due to physical activity, will decrease right ventricular filling, will decrease venous return. And therefore, they may increase murmurs associated to the right categories of the heart, like murmur in hypertrophic cardiomyopathy or mitral valve prolapse. So that's important, and please remember that when we'll talk about those valve heart diseases or the less topic at today's semester when we'll talk about myocardial disease, another quite complicated issue. A patient with hypertrophic cardiomyopathy will have symptoms similar to, signs similar to aortic stenosis in significant degree. Standing will decrease venous return again, because blood will be pooled in lower extremities and will decrease again, return to right edges of the heart. Valsalva maneuver, as we decided, will decrease cardiac output and will increase heart rate, creating overload to the left cavities of the heart. Mitral regurgitation, nice procedure that may be done just, for instance, during auscultation or during ECG when you're carrying out auscultation of the heart, and definitely you cannot send patient that he or she will run somewhere. Is a hand grip. Well, that will increase systemic vascular resistance, will increase resistance, and for instance, again, hypertrophic cardiomyopathy, the symptoms may become more obvious. And right-sided heart murmurs will be increased by inspiration. We already talked about that. Innocent murmurs. Innocent murmurs are soft, of low intensity. Typically, there will be no or zero radiation. Intensity typically grade 1 or 2, hardly audible. Is it important? Yes, that is important. So you need to pay attention to intensity and pitch of the murmur. But what will be much more important in that patient is that first and second cardiac sounds will be absolutely normal. That is the basic criteria of the functional murmurs. If heart murmurs are preserved, in most of the cases, patient will have no parallel heart disease. Functional means murmur that will develop without parallel heart lesion. Besides that, patient may have, but not necessarily, normal splitting. For instance, at inspiration, there will be splitting of S2 over tricuspid area, but only during the inspiratory phase. There will be no ejection sounds. Typically no diastolic murmurs in that case, because in diastole, murmur will mostly flow passively. And therefore, if innocent murmur may be explained, for instance, by some kind of discoordination of the shape of the heart, size of the heart, and greater vessels in children, in pediatric patient, in adolescents, or it may be associated to sclerosis of aorta in elderly people, that cannot be the explanation for diastolic murmur. And definitely, please don't forget that there is inspection, palpation, percussion of the heart, and there should be no signs of ventricular hypertrophy, ventricular dilation if we talk about functional murmur. Here it is, that is a PCG in second left interspace. That is the PCG over the pulmonary artery. And in that case, we should not assess S1. Here it is, but it should be assessed on the apex of the heart, not here. We have absolutely normal second heart sound. S2 is normal. Please notice the normal interrelation. That is S1. And that is a normal physiological delay of the pulse wave on carotid artery. That's how it happens normally. So first patient will have the ventricular complex at the ECG. Second patient will have S1. Then patient will have with slight delay wave on carotids. A wave on radial artery will be somewhere here. So it's definitely not reliable marker for detection of the systole ventricles. Even the wave on carotid will be slightly delayed, but should not try to compare your auscultatory data to radial artery, because definitely they will be quite significant and not always unpredictable delay. Okay, so once again, heart sounds in a patient will be preserved. Murmur is soft and of low amplitude. That is the midsystolic murmur in aortic stenosis. Location obviously will be in typical location for aorta in second right interspace. Radiation typically will be to all great arteries of greater circulation, to the neck, or maybe to subclavian arteries. But unfortunately for us, maybe also down to the left sternal border, sometimes even towards the apex. So that is the radiation by sternum, by bones. That is important because it may confuse you. So therefore, in that case, please pay attention to the presence of radiation to the great arteries. If it will be present, that is the aortic stenosis. Quality, typically harsh. If well, you deal with the radiation of the murmur to the apex, at the apex it may be more musical. It will be heard best if patient will sit, will lean forward, as we decided already, and there may be decrease in aortic component. It means that, well, along with the progression of stenosis, there may be lower and lower and lower intensity of S2, or sometimes there may be delay in aortic component in relation to pulmonic. Typically, it will be, well, vice versa, opposite. In healthy patients, there may be slight delay in pulmonic component in contrast to aortic. In that case, there may be, well, opposite situation. Anyhow, decrease in S2 intensity is a marker of progression of stenosis. Well, and in some patients, there may be also aortic ejection click, ejection sound, especially in the case of congenital cause of that. That is the PCG. Well, first of all, let's start from the start. Start is the electrical systole, that is the ventricular complex at the ECG. Then we have a first cardiac sound. Here it is. That is S1. That is a low frequencies filter, medium frequencies filter. So just, well, two acoustic filters, two, well, so to say, microphones at the apex. Then in the very earlier phase of systole, you can get ejection click, recorded both in medium and low frequencies. And then very, very loud, very harsh, very rough. You can see how, well, differs its shape, the PCG from the functional. Well, that is the innocent murmur. It's very soft, very, very uniform. And that is a recording of well, organic murmur in aortic stenosis. And definitely it's very loud. At the apex, we should not pay much attention to S2. That is not the point for assessment of second cardiac sound. And well, definitely it will decrease, but for that, you need to look to the aortic area. What will happen to second heart sound there? And beside that, please pay attention to the presence of third cardiac sound and fourth cardiac sound. Third cardiac sound is passive filling of ventricle, or so to say passive filling, because definitely that process is controlled by relaxation of ventricle, but there is no contraction at that phase. It's just, well, controlled relaxation. Presence of third cardiac sound means presence of the dystrophy of the left ventricle, and it means that the late stage of disease, means poor prognosis of the patient. What also bad is the presence of the fourth cardiac sound. That is a marker of overload of atrial activity. We'll discuss it at the last class of the semester when we'll talk about types of myocardial dysfunction. Please remember that the atrial should contract, atria should contract at the very end of diastole. So there is plenty of blood. Ventricle is already filled by blood at the end of diastole, and the very last portion should be ejected actively due to contraction of the atrium. And if ventricular myocardium is very stiff, if it's severely hypertrophed, there will be no enough space for that extra amount of blood at the very end of diastole blood that should be ejected by the contraction of atrium. And in that case, the onset of atrial systole will be significantly well distanced from the onset of ventricular systole, and that will result in splitting, separation of atrial component from other components of S1, and that's how you'll get independent fourth cardiac sound, separated atrial component of first heart sound. Midsystolic murmur in pulmonic stenosis actually will be similar to that in aortic stenosis. The only difference will be that the amplitude will be lower, it will be softer, not as significant, and definitely in that case, there may be delay of pulmonic component in comparison to aortic component. It will be audible where it should be in second interspace. Sometimes it may go slightly down in third left interspace. Shouldn't be confused by that. The typical location, sorry, is second interspace. Radiation sometimes may be again confusing. It may go upward towards left shoulder and neck, but it will be never heard over subclavian artery and never will be heard over a carotid artery. That's important. So the only direction towards, but not onto subclavian or carotid arteries. In severe stenosis, there will be splitting shown here of second cardiac sound, significant decrease in P2. Sometimes there may be ejection click. And please pay attention that the distance from the normal aortic component to the second pulmonic component, delayed component, will represent severity of stenosis. So that distance there will be the most significant, the most severe will be the stenosis. That is pre-operative recording in a patient with pulmonary valve stenosis, very, very low S1, but again, it's second left interspace. So we should not assess intensity of first cardiac sound at the base of the heart. Very severe, very intensive murmur that is more or less of diamond shaped. Normal aortic component and significant delay in pulmonic component. And that is same patient post-operative. Please compare the intensity of the murmur significantly decreased. It's not as harsh, it's not as rough in its pitch. And aortic component, well, actually it's opposite. Pulmonic component became much closer to aortic component as compared to pre-surgical stage. So therefore, the distance between the aortic and pulmonic components may be regarded as degree on one hand of severity of stenosis, and on the other hand, it may be the marker of success, efficacy of surgery. Holosystolic murmur in mitral regurgitation. That murmur obviously will be caused by retrograde blood flow or blood from left ventricle back into left atrium. And then there will be extra return of blood into left ventricle. So due to that, first of all, location will be definitely at the apex. Radiation will be upward to the left axilla. Quality will be, intensity will be different. Most commonly it's loud, but sometimes it may be soft. It will be associated to the apical thrill. Pitch medium to high, so it will be better heard by phonenoscope. Low in quality. S1 typically will be decreased. We were discussing that at the class devoted to cardiac sounds. Once again, who can remind me what will happen? Why there will be significant decrease of S1 intensity in patient with mitral components? What will happen to the patient's heart? Why there will be decrease of S1? Gabriel, any ideas? Sumaya? It will be due to connection of the cavity of left atrium to left ventricle during the systole. So due to that, there will be no isometric or isovolumetric component in S1, and that's why S1 will be low, because the basic component associated to muscle function, muscular component, will disappear completely. And another important point that your patient will have third cardiac sound. Again, we discussed that in our previous class. It will appear in a patient with absolutely normal contractility, will just reflect volume overload. A patient may have absolutely normal left ventricle, absolutely functional left ventricle. There'll be no dystrophy. There'll be no extra vibrations due to loss of cardiac muscles. But there will be just too much of blood that will return from the left atrium in higher volume. After regurgitation, there will be increase in return of blood, and that's why there will be a development of third cardiac sound. That is PCG in, let's start maybe with the apex. In mitral regurgitation, almost unnoticeable as one. Please pay attention that you can hardly see it, and you'll hardly hear it during auscultation of the patient with mitral regurgitation. It will be merged to the following murmur. Murmur is not as diamond-shaped as in the case of aortic stenosis, but still there is slight increase in the shape. I told you that the shape of the murmur will depend upon the pressure gradient, interrelation of pressure in the left atrium and left ventricle. The gradient may slightly be increased in the middle of systole, and in that patient, there may also be slight increase. S2 should not be assessed at the apex. It should be assessed at the base of the heart and in the second left interspace. Parameter, by the way, second left interspace is the point of which valve? Second left interspace is which valve?
Second. Pardon once. Second left.
Second left interspace. It's which area? Which valve should be
It's for aortic valve. I mean semilunar cuspid valve.
Parameter. No. It's written at the slide. You should just be
tricuspid valve. S2.
Second left. Second.
Is it for the aortic?
It's pulmonic.
Pulmonic. Oh.
Aortic is second right interspace. Second left is pulmonic.
Okay. Yes.
And at the pulmonic area, accentuation of S2 will be the marker of overload of lesser circulation by blood. Third cardiac sound will appear in the patient just as a marker of disease, not as a marker of decompensation. In that case, you can see a patient at the very beginning of disease. The first cardiac sound is preserved. It's very nicely audible, quite soft systolic murmur, again with some trend for increase in the middle of diastole, though it's not typically diamond-shaped. And we have very loud third cardiac sound. So even at the very, very beginning of mitral regurgitation, patient with absolutely normal left ventricular muscle will have third cardiac sound. So that will be the gestable manifestation of the basic feature of the disease, the volume overload of left ventricle. And by the way, please pay attention that third cardiac sound is surrounded by the very soft murmur that also may be possible in a patient due to, again, extreme amount of blood that left ventricle will receive. It's abnormal after regurgitation, and that's why there may be some kind of turbulence around the murmur. In tricuspid regurgitation, there will be similar changes. The basic difference definitely will be the location. Location will be the base of the Fourier process, so that is lower left sternal border. And intensity of the murmur. Intensity will be significantly lower than the murmur in mitral regurgitation. Radiation may be to the right of the sternum, sometimes down to the forehead area, and sometimes, maybe left to the left midclavicular line. Quality blowing. Intensity will increase with inspiration. That's important. And again, third cardiac sound may be audible now over the left sternal border, again in the area of auscultation or the tricuspid valve. That is the PCG phonocardiogram. in the fourth left interspace that is very close to the base of the fourth process. And you can hear, well, after the first cardiac sound, that is S1, that is the very soft murmur. Very, very gentle. Please pay attention to very intensive fluctuation of the pressure in jugular, internal jugular vein. That is so-called positive venous pulse. We'll talk about that a bit later. I hope there'll be enough time today to discuss that. That is positive, first of all, that is abnormal. And second, it's very huge. So pressure in right cavities of the heart grows significantly higher in that patient. That is the diastolic murmur in aortic regurgitation. It's decrescendo because the pressure gradient will be very high, very intensive, just right after S2, and will decrease along the diastole. Location will be first in the second right interspace, but there'll be also murmur audible in Watkins area, that is third to fourth interspaces. Sometimes it may also involve second interspace. Watkins area is third to fourth interspaces, and that will be the point of maximum intensity of that murmur. Radiation back to the left ventricle. So we're talking about the jet of blood that will get from aorta to the left ventricle, and therefore from the Watkins area. That is the area located over the aortic valve itself. Radiation also will be to the apex of the heart, to the left ventricle. Quite low intensity from first to third grade. It's high pitch murmur, so better use diaphragm, better use phonoendoscope. Blow in quality, quite gentle. Sometimes may be mistaken for breath sound, for vesicular or bronchial breathing. Therefore, first ask patient to hold breathing before auscultation, and the patient should hold breath at expiratory phase, at exhalation, so there will be no extra air between heart and chest wall. Patient should be definitely seated and lean forward, like shown here. So phonoendoscope is positioned to the Watkins area, in between aortic area, that is second left interspace, and the apex of the heart. That will be the jet of blood flowing from aorta to the left ventricle, and the loudest murmur will be over aortic valve itself. Radiation all down to the apex. That's how murmur in aortic regurgitation will look like after a second heart sound. Quite intensive decrescendo murmur. Quite typical for that murmur and quite intensive. It's also rough because there is destruction of the cusps of the valve that is perforated in infective endocarditis. That's why murmur is so loud and so rough. Again, that is crowded pulse, second heart sound, here it is. And well, after S2, there is decrescendo murmur. By the way, please pay attention to collapsing, a very sharp, very rapid increase and rapid decrease of aortic pulse on carotid artery. That is collapsing pulse wave. Again, it's due to rapid pressure increase and rapid decrease of the pressure in a patient with destroyed aortic valve. Now, mitral stenosis. Mitral stenosis will result in diastolic murmur of the filling of the ventricle. That will be the murmur of the turbulent jet of blood that will try to get, well, in autograd direction from left atrium into the left ventricle through stenosed mitral valve. So it's narrow, and jet of blood will be turbulent. What do we need to pay attention to? First of all, that murmur should appear only after opening snap. Opening snap is the sound of the opening of the mitral valve. The cusp of the mitral valve should open. Normally, that event will be absolutely silent. And in the case of mitral stenosis, it will become loud. Therefore, after S2, there will be opening snap, typically after about 12 milliseconds. You can hear extra sound that will be the within 6 to 12 milliseconds. That is the time of opening snap. There'll be extra sound only after that. Only after mitral valve will open, there will be first passive component, just high pressure gradient across mitral valve, and blood will flush rapidly into left ventricle. Nice. What will happen at the very end of diastole later? At the very end of diastole, just before systole, there will be active ejection of blood due to contraction of atrium. And if it will be present, patient will develop presystolic enhancement of the murmur or just a presystolic component of the murmur. That will be the marker of active emptying of the atria in the case of contraction. But that will not always be the case, because in some patients there will be no atrial contraction due to either overload or a secondary arrhythmic complication due to, for instance, atrial fibrillation. Therefore, there will be two components, midsystolic and mid-diastolic and presystolic. Location murmur will be typically limited to the apex. Radiation typically will be absent. Pitch will be low, so you should use stethoscope without membrane, without diaphragm, just bell. S1 will be very loud, again, due to muscular component, due to empty left ventricle, they will be very loud, so-called cannonball S1. And don't forget about the opening snap, should always precede diastolic murmur. Diastolic murmur may be assessed by different means. For instance, you may also measure, besides the width, the area of the mitral valve orifice, may also pay attention to the amplitude of the movements of the mitral valve, another marker of sclerosis of the mitral valve. And this is how it may look like. Very loud S1, S2, and after S2 you can get opening snap quite close, so within 6 to 12 milliseconds. And after that you can get something very, very, very gentle, very mild. That will be the passive component, and the maximum of the murmur will be at the very end of diastole at the contraction of atria. So that is the active component indicating that atria, at least left atrium in a patient, is functionable. It's contracting. It's not as overloaded that it will be unable to increase pressure. Austin-Flint murmur. That is a murmur that may happen in the case of so-called functional stenosis of the mitral valve in patient with aortic incompetence. Again, we'll try to discuss that the class devoted to aortic incompetence. Blood will regurgitate from aorta, where pressure is extremely high, to left ventricle in diastole. Left ventricle is relaxing. It's ready to receive blood from left atrium, but there is a very strong jet of blood from aorta. Normally, jet of blood from atrium to ventricle is very smooth, very, very low pressure gradient. Yes, Kave. Mamagani, Kave Mamagani, will you raise your hand? Any questions? Okay. You may text me in the chat if you wish to. But pressure in aorta is significantly higher than pressure in left atrium. That's why aortic pressure will raise the cusp of aortic valve, will press it, press it upwards. So that jet of blood will raise and slightly shut half of or about that of mitral valve. And in that case, patient will develop extreme murmur of so-called functional mitral stenosis. Patient may develop tricuspid stenosis. That is, again, a recording of the jugular pulse. You can see the changes that we'll discuss slightly later. changes the downslope of the A valve. A wave in that case will be present. But point is that in tricuspid stenosis, you'll get diamond-shaped murmur over pulmonic artery that will just resemble the diamond-shaped murmur in aortic stenosis. Again, there may be decrease in S1. Sometimes there may be decrease in S2 over pulmonary artery. Good. Well. Again, that is tricuspid stenosis. And in that case, as we had in mitral stenosis, pre-systolic murmur. So in that case, we are talking about right atrium. That's function is preserved. It's contracting. And at the very end of ventricular systole, it's able to increase pressure and produce end diastolic pre-systolic murmur. Pericardial friction may be seen in patients with pericarditis. In that case, there may be issues in venous pressure. There will be elevation of pressure in general. And on that background, there will be deepening of X-wave, of filling of atrium. But I think we'll rather discuss that when we talk about venous pulse. Location of murmur in ventricular septal defect, typically by the both edges of sternum, and pulmonary artery stenosis is typical. It's obvious that the standard point for auscultation, second left interspace. Rough murmur in ventricular septal defect. It may be sometimes biphasic, but in that case, it's seen well only in the systole. Here it is before the second cardiac sound. Here it is. And patent ductus arteriosus. Sometimes it may result in machine murmur, but in that case, it's just biphasic, systolic, and diastolic components. And brut de Doppler. That is venous hum. Due to very rapid blood flow, murmur, sometimes very intensive, may be heard over jugular veins. Compression, if you just press over the jugular vein by a endoscope, will result in a complete block of that murmur. There will be nothing will be heard here. When you remove compression off, that murmur will reappear. Typically marker of anemia or any other causes of more rapid blood flow. Good. Well, do you have any questions so far concerning auscultation? Please don't be confused by amount of data. I think we'll discuss at least some basic features when we talk about valvular heart disease. Anyhow, if you have some questions, you may well either raise your hand in the Zoom or just switch your microphone and we'll just speak forth or text me in the chat. Anyhow, while you are thinking, let's shift to veins. First, and something very simple and not always reliable, will be assessment of the superficial external jugular vein. Here it is. Its overfilling may be associated to different reasons. It may be related to, for instance, emphysema of the lungs, and there is none. Please pay attention to patient episodes. They're not protrudian. Definitely patients have no at least obvious emphysema. It may be associated to some focal lesions, some tumors in the chest cavity. It may be associated to pericardial disease, like effusive pericarditis, pericardial effusion, or it may be associated to constrictive pericarditis, when there will be attachment of pericardium that may block presence flow of blood into right cavities of the heart. Cardiac tamponade may be another very dangerous marker that may result in overfilling of veins, both deep and superficial veins. Cardiac tamponade is accumulation of fluid in pericardial cavity, pericardial sac. That will be enough to block the flow of blood back to the heart. Causes suggestible, as I told you, it may be related to malignancy, some focal lesions, some masses. It may be seen in patients with chronic renal failure with overaccumulation of fluid in the body, including pericardial cavity. Sometimes it may be seen in patients with hypothyroidism that will have a tendency predisposition for overaccumulation of fluid. What will be the physical signs? Pulsus paradoxus. So there will be decrease in intensity of pulsation when patient will breathe in. If normally inspiration will result in very rapid increase in pulsation of arteries, in that case there will be opposite situation. Well, breathing in will cause even more severe block of caval veins, and that will result in decrease in intensity pulsation. There will be distension of superficial and, what's more important, internal jugular veins. Sometimes patient may develop distant cardiac sounds, so they will be muffled, as if you have some kind of a pillow in between your phonoendoscope and patient's heart. Heart sounds will be heard very distantly. Obviously, patient, due to decreased return of blood, will have tendency for hypertension. Well, yes, pulsus paradoxus, low voltage on the ECG, another important marker. Hepatojugular reflex is sometimes called positive Pasteur-Rondeau sign, a situation when you'll press over the lever. It's quite a simple maneuver. Unfortunately, I was unable to find the photograph with that. It's just pressure over the right hypochondric area, over the lever area by one of your palms. And at that time, you should see what will happen to jugular veins. If you see engorgement of the veins, it was absent or more intensive engorgement, it considered positive. So positive Pasteur-Rondeau sign is overfilling distension or increasing distension after pressure over the lever area. Kussmaul sign is paradoxical increase in jugular venous pressure that may occur during inspiratory phase. Again, it may be the marker of constrictive pericarditis. So that is the inspiration. And in that case, in contrast to normal situation when jugular venous pressure should decrease, presence of block just before the entrance into the right atrium will result in the blockage of jugular veins, of caval veins, and will result in increase in jugular venous pressure. Jugular veins. What I showed to you the previous slides was superficial jugular vein. Here it is. That is a superficial vein, and internal vein is here, very close to carotid artery. That is a problem because in many patients, you'll be unable to differentiate the internal pulsation of the internal jugular vein and conduction of the pulsation from the carotid artery. For that, you may use hepatojugular reflex. So if you're in doubt what's actually pulsating, just carotid artery, that may be even an absolutely healthy patient, or it's pulsation over the internal jugular vein itself, press over patient's liver, and if there be increase in pulsation, that is pulsation over the vein. If there will be no change, that was the just conduction of pulsation from carotid artery. Very, very simply, very briefly, that's how the general outlook, the shape of the venous pulse will look like if we talk about internal jugular vein. During the systole, there will be decrease in filling of jugular vein, and there will be collapse of jugular veins. So we call that negative venous pulse. During the systole, there will be increase over dilation of carotid artery. So carotid artery will become larger. There will be a positive pulse wave, and that will typically be associated to collapsing of the jugular vein that is called negative and normal venous pulse. In diastole, there may be some increase of jugular vein first, then there will be some slight drop, and then again, before the next systole, there will be increase in the volume of jugular vein. Well, how can you differentiate jugular and carotid pulses? First, palpation. Jugular venous pulse mostly will be assessed by inspection. It's hardly palpable or not palpable at all. Carotid pulse is nicely palpable, always palpable. Waveform, it's multiform. Typically, there'll be at least, well, 2 or 3 components. So you may feel the component A, the atrial contraction, component V, that will happen in ventricular feeding. So at least 2 components will be visible. Only single wave at the carotid artery. Quality soft, undulating. So if you press by your finger, you may nicely compress it. And extremely intensive pulsation that is almost impossible to compress. That will be the carotid artery. Pressure, so to say, obliterated waveform will be, so you will obliterate the pulsation by pressure. No effect, you'll be unable to compress typically the gentle pressure. Carotid artery. Inspiration will decrease. Definitely, if it's not patient with constrictive pericarditis with viscous mouth sign, inspiration will decrease height of the wave. No effect on the carotid artery. If patient will sit up or stand up, if he or she was lying, that will again decrease height of the intensity pulsation, and Valsalva maneuver will increase the height, just because Valsalva maneuver will increase the pressure in the chest and will prevent blood from flowing into the cavity of the patient. Please pay attention that the normal posture should be at the angle of 45 degrees. The patient should lie like that. So 45 degrees should be for the whole upper portion of the body, like that. That angle should be 45 degrees. You may use a torch to see the meniscus of the pulsatile area. So the portion of the jugular vein that is pulsating, that will go up, 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 and then stop, and then disappear, and again up, 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 and you'll get the top portion, the meniscus of the pulsatile portion, should be measured at that position of the patient at the 45 degrees. I need to mark the location of the angle of Lewis. That will be a very important point, starting from which you'll measure the jugular venous pressure. And then you may use a straight edge, the ruler, to measure the distance from the Lewis angle up to the meniscus. So that should be the horizontal, and you need to measure distance like that. How many centimeters? Typically, well, in a healthy patient, there will be about plus 3 cm, about this, not more than 3 cm. From the Lewis angle down to the center of the right atrium, there will be plus 5 centimeters. Therefore, the normal central venous pressure should be about 10 centimeters. Jugular venous pressure about, well, less than 5 centimeters. Here it is again the scheme. 5 centimeters to center of the right atrium. 2 rulers, one will be horizontal, another is vertical and located at the Lewis angle. You measure the distance from the Lewis angle up to meniscus, the top of the pulsatile portion of jugular vein, internal jugular vein, and measure. So let's say, as in this example, they measured 3 centimeters. 3 plus 5 equals plus 5 equals 8 cm. So that will be the 8 cm of water pressure in the right atrium, in the right cavities of the heart. And if you wish to convert that into millimeters hydrogram, just multiply to 0.75. So if you multiply 8 to 0.75, you'll get 6 millimeters of hydrogram. That is the already practical part. Let me erase all my well, drawings. Definitely, in that case, it will be much more than 3 centimeters, as shown here at that ruler. So patients have an elevation of central venous pressure, and it means that there is well, some incompetence of the right ventricle, right ventricular failure. Good. Now, in much more details, talking about normal jugular venous pressure, we have several waves. Wave A will represent the positive wave due to contraction of the right atrium. Here it is. Right atrium will contract, will empty itself into right ventricle, and at that time, pressure in the jugular vein will slightly increase. Then the pressure will go down because there'll be less blood in jugular vein. It will be emptied partly into right atrium. But then there'll be again suddenly some increase in the pressure, wave C. That will be the positive deflection due to bulging of the tricuspid valve at the moment of the onset of the ventricular contraction. So very onset of systole of ventricles will be indirectly well visible through the tricuspid valve on the jugular vein as wave C. That is the beginning of systole. So at that moment, you should see that the positive pulse on the carotid artery or first cardiac sound. X wave. So actually, this also may be called X wave. That is the negative wave representing the feeding of right atrium from the jugular vein. V, that is a positive deflection, representing a passive increase in pressure along of filling of right atrium. So there will be more and more and more blood in the right atrium, and in the late systole there will be some increase in pressure. Pressure will be conducted from atrium that's filled by blood to jugular vein. And Y wave is the negative deflection due to emptying of right atrium upon ventricular relaxation. So most obvious will be that negative wave in healthy patient, X wave, that typically will coincide to a pulsation of carotid artery, and you will describe that as negative venous pulse. So that is a normal waveform, that is a QRS complex, it's systole, cardiac sound, carotid artery will be dilated, and jugular vein will be collapsed. If patient will develop tricuspid regurgitation, there will be increase in that V wave that will be increased, and sometimes will also encompass C wave. So that will represent the positive venous pulse in a patient with tricuspid regurgitation. In that case, blood when patient's right ventricle will be contracting, will be ejected on one hand in the pulmonic artery, on the other hand back in the right atrium, and the wave will be conducted to jugular vein through right atrium, and from left ventricle it will be conducted to carotid artery, and therefore your patient will have synchronous increase in pressure in carotid artery and in jugular vein. And there will be also increase in pressure. That will be what we call positive venous pulse. Again, that is a normal X wave. Atrial filling will result in collapse in healthy patient of jugular venous pulse at the moment of dilation of carotid artery. Well, and now we have almost no time. I have just a few slides related to assessment of the blood pressure. I think it's quite obvious. We use Korotkov sound, and when our sleeve will be relaxed until the systolic pressure, there will be some pulsatile portions of blood that will get from brachial artery to our phonoendoscope. When there will be smooth flow and the pressure in the sleeve will be under diastolic, we hear nothing. So the portion in between systolic and diastolic pressure will be the area when you'll hear Korotkov sounds, and that will represent pulse pressure in our patient. That's how it should be measured. If your patient's hand will be too large to use a standard cuff, you may use, by the way, the cuff on the patient's forearm. You may use, or actually you should, well, measure pressure in patient's thighs, applying the fundoscope to popliteal artery from patient's back, so patient is lying face down, patient is prone. For assessment, for instance, of stenosis of abdominal aorta. And again, if that will not be enough, you may use standard cuff on patient's ankle and apply a fundoscope to dorsal paris artery or posterior tibial artery. For edema, I think it's quite obvious. Well, you need to press by your finger. One finger will be enough, typically index finger, to any superficial bones, and assess presence of pitting after that. Degree of pitting will be assessed in grades. 1, slight pitting, 4, very deep pitting that will last for 4 to 5 minutes. Well, that's all for today. Now, if you have some questions, you may switch your microphones, ask me some questions if you have some, or you may just text me in the chat. And yes. Yes, that is the quotation from the first or maybe second class devoted to radial pulse. So I just pasted those slides devoted to venous pulse from the presentation. I think it was 1 week and a half ago, 2 classes ago. You may find those slides in PDF related to examination of patients' radial pulse. Good. I mean, just repost them once again if you wish to, but they're all present in the slides related to just examination of arteries and veins. Good. Any other questions? Yes. Good. No. Thank you. Well, if you wish my slides, I can just repost them. But all those slides will already presented as PDF. Good. Thank you. Any other questions? If there are no other questions, then I have to announce the next topic. It will be the first topic in the ECG. The basics of the ECG, assessment of the electrical axis of the heart, electrical vector of the heart. We need to discuss how actually the heart is activated. And we need to also deal with the hypertrophies of atria and ventricles. So that will be the topic for the next class. Everything up to blocks. I hope that maybe tomorrow I already post new slides, but actually most of them that I will demonstrate you are presented in the slides devoted to the lecture. Well, I posted my lecture in the ECG that was delivered to you actually in live. So most of those slides will be from the lecture. You may already today find my lecture in our Google Class, or you may find a lecture at the web page of the university. Once again, I have just my personal request to all of you. Please visit our web page because it's important, and all our activities should be marked, should be verified by the web page. So please find my lecture there. University web
The link
page.
you sent us. The link you sent us in the
Yes,
classroom for
it's
this
not working.
portal. It's not working.
Pity.
Yes, it's not working.
And
It
if
says
you
that we
just
can join.
type dl.sechnov.ru, is it
Yes.
the link to?
Yes, this side is
But
working,
it says
the
that we
main.
can't join the course.
Yes.
Really?
Yes.
So you should use your, I think, students' ticket number Some kind of registration should be
No,
required.
yeah, it's already
No.
registered. And it says, вы не можете записать на этот курс.
Pity. Can you please, text me maybe, now or in the Google Class names of the students who are unable to attend, to enter the web page of university? Or is it true for all of you?
No, it's
Or
not
only for some?
the
Yes,
university
it's true
page.
for all
It's
of us.
only the propedeutics material that you sent us there. The link you sent before.
I
I
can
see.
send you a screenshot of it if you want.
There is
Yes,
no
yes, I need
material.
that
See it. Yes,
because
will do
I
it.
need to talk to administration of the web page while trying to decide what's happening, why it's like that. Good. So please send me screenshots and names of those who cannot attend the Google Class right now, because after I'll switch over the conference, you'll be enabled to text in the chat. So I'm waiting for those who cannot get to the web page, and that will be over for today. Again, please try to switch on all of your cameras on your phones, tablets, and so on. And please be ready for next class devoted to ECG. Good.
I have
Yes.
a question.
Smile. Yes.
You said that we can use our profile, our student profile, right, for this
Well, it's supposed to
subject.
be like that. So you should type your number of your
But
students ticket, and
yes,
voila. Yes.
yes, I did it, but it doesn't work at all. And did you post any of this presentation on this website too?
No.
No.
First of all,
Okay.
all lectures should be absolutely free for all students. Second, definitely all stuff, all the data for the classes. It's called in Russian материалы для самостоятельной работы. They also should be absolutely free, open for all of you. So I need to check that out with the administration of the portal, finding what's wrong and why you are switched off from the web page. It's somewhat strange. Okay. Good. I see that still there are a lot of students that type in their names. So quite a lot of students from different groups unable to use the portal. That's a pity, because from their side, from the side of our officers, were pressed to switch everything to the portal, to the web page. We are not forbidden from using other platforms, but everything should be mediated through the web page. Only link at the web page from Google Class, for instance, or to the Zoom. I see. Good. And don't forget for today's class to fill the Google form and to fill down your name into the table, so I will be able to take into account the attendance. Good. Well, still people are posting their names. It's a huge list. Good.
I think
Okay.
it's for all of us.
Sorry?
For all, I think it's
I
for
think
all
that's
students.
for all groups, because I see students
Yes.
from 66, 70, 74, 72, 79 group even. Well, yes. Okay. Good. Well, that'll be all for today. Please switch off your microphones who don't wish to speak to me, because I hear some kind of, I think, Chinese language. It's definitely not the language of my student. Somebody's TV. Good. Well, please be ready with the basics of the ECG. I will recheck presence of the lecture PDF, and I think maybe I'll repost maybe some rearranging some slides as the slides for the class. For now, goodbye. Again, I think I'll log the Google form for the attendance for today's class. maybe in 10-15 minutes. So don't forget to send your names to the Google form for today. And see you next Wednesday at 11 p.m. Sorry, sorry, at 11 a.m. at 11 Moscow time. So same time as
Goodbye,
usual.
sir.
Sorry, we're meeting
Goodbye.
at 1 p.m. So it's 13. Yes, 1 p.m. Yes, correct. 1 p.m. Wednesday. Good. Goodbye.
Goodbye, sir.
Bye.
Bye.
Thank you, sir.